It's a beautiful day here. We were fortunate to have a tour of the Acropolis Museum yesterday, and it's quite wonderful. If any of you haven't seen it, you should definitely do this. Today we're going to talk about feeding the brain of the preterm infant. Can you see okay, or should we put the drapes down a little? If we can find the control. Well, the goals of intensive care of the preterm infant are, first of all, to allow the baby's survival with minimal medical complications and the best possible health, and also, of course, the best possible neurodevelopmental outcome, which depends on brain growth and development. Here you can see the brain at about 23 weeks and about 32 weeks and at term. The period of maximum brain growth and therefore vulnerability to growth failure spans the third trimester of fetal life and the first postnatal months. Thus, the preterm infant's brain is highly susceptible to the effects of inadequate nutrition. Early protein and energy intake affects brain development and function. Early growth correlates with later cognitive and motor performance. Advantages of human milk for brain development, and the importance of specific nutrients. These are the four parts of the presentation. I'm going to go through each one of these. Some of this is going to repeat what you heard yesterday. In fact, I'm going to cite some of the same studies that Dr. Hay and Dr. New and Dr. Martin cited. This was the paper by Stevens et al. At Brown University. In infants with birth weight less than 1 kilogram, after adjusting for confounding variables, energy and protein intake in the first week of life were each associated with the Bayley-II Mental Development Index at 18 months. And as you heard yesterday, each increment in energy intake of 10 kilocalories per kilogram per day was associated with a 4.6 point gain in the mental development index. And each increment in protein intake of 1 gram per kilogram per day was associated with an 8.2 point gain in MDI. Higher protein intake was also associated with better gain in length. This is also a study that you heard about yesterday by Isaacs et al. The beneficial effects of early nutrition extend into childhood and adolescence. These were infants from the study in the United Kingdom by Lucas et al. Preterm infants less than or equal to 30 weeks gestation were randomized to high versus low nutrient feedings. The high nutrient feeding was the preterm enriched formula, and the low nutrient feeding was term formula or unfortified donor breast milk. The high nutrient feedings were higher in energy, protein, minerals, and micronutrients. And 95 patients were examined at 8 years and also in adolescence at a mean of 16 years. So this is one of the best studies in terms of the length of the follow-up period. Here's what they found at 8 years. The infants with the high nutrient diet had higher verbal intelligence quotient scores, higher performance IQs, and higher full-scale IQs. And the difference in the full-scale IQ was about 7 points. Now, when they examined the same patients at 16 years, they still found a difference in the verbal IQ and almost in the full-scale IQ. And there was a difference in verbal comprehension, but not in performance IQ and not in freedom from distractibility. But I think you would agree these are pretty significant effects and clearly demonstrate that nutrition has an important impact on brain growth and on later cognitive function. Now, as we said, early nutrition affects brain development. We also know that early growth correlates with later cognitive and motor performance. This is a study by Belfort and colleagues, 249 infants, less than 1250 grams birth weight. They had Bailey II scales performed at 18 months corrected age, and they examined the correlation between the growth rate during 3 different periods and the Bailey II MDI and PDI. PDI is Physical Development Index. The 3 periods that they looked at were the growth from 1 week of age to the term equivalent, or 40 weeks postmenstrual age, from term to 4 months, and from 4 to 12 months. What they found was that the growth during the earliest period had an effect on both the weight gain during that period was associated both with the MDI and the PDI at 18 months. Length gain was and head circumference gain were associated with the PDI, but not with the MDI. The next period of growth from term to 4 months, there was a relationship between length gain and PDI, but not weight or head growth. And then from 4 to 12 months, the rate of growth had no measurable impact on the on these assessments at 18 months. This is another study. This one is from the NICHD Neonatal Research Network, published by Aaron Krantz. And he looked at, he divided the patients into 4 groups based on their rate of growth in the hospital. And these are quartiles. So this is the group with the slowest growth, and this is the group with the highest growth. And you can see that the weight gain was different. And there was an association of the rate of weight gain with abnormal neuroexam, cerebral palsy, MDI, PDI, and the rate of neurodevelopmental impairment. And neurodevelopmental impairment is defined by this network as MDI or PDI less than 70, cerebral palsy, blindness or deafness. So you can see that there were important differences in all of these measures. So better growth portends better neurodevelopmental outcome. If we look at this based on head circumference gain, we see the same thing. The babies that had the best gain in head circumference presumably had the best brain growth, and they had also the lowest rate of abnormal neuroexam and cerebral palsy and neurodevelopmental impairment, and also the lowest rate of low scores, both MDI and PDI. Head growth to age 7 was examined by Cook et al. And was found to correlate with cognitive but not motor outcome. This study involved 280 children born before 32 weeks gestation, and they were assessed at 7 years with weight, height, body mass index, head circumference, and these formal assessments of various aspects of cognitive and motor function. They found that the head circumference at 7 years correlated with verbal IQ, performance IQ, and total IQ. Okay, you've just seen the lovely poster of Despina and have heard a little bit about the importance of promoting breastfeeding, and you've already heard yesterday from other presenters, but we're going to reiterate specifically the benefits of breast milk for brain development. This is the original study of Alan Lucas and colleagues in the UK. 313 preterm infants with birth weight less than 1,850 grams, randomized to different feedings as a supplement to mother's milk, or as the sole diet if the mother chose not to breastfeed. 300 infants were examined at age 7.5 to 8 years with Wechsler Intelligence Scale for children. What they found was the mothers who chose to provide their own milk, the babies had a 10-point advantage in verbal IQ. This is uncorrected. I'll show you the adjusted values on a later slide. Performance IQ was also 10 points higher. Overall IQ was 10 points higher. 10 points is pretty significant. That's a lot of, that'll make a difference in the child's quality of life. Now, a very interesting aspect, they looked at, they broke this group down, the mothers who chose to provide milk, into the ones who wanted to breastfeed but were not able to, and the ones that were able to. And here you can see that the mothers who wanted to give their milk but were not able to for some reason, their babies had scores like the same as the mothers who chose not to provide their own milk. And the mothers who were successful had the same scores as the overall for this group. Now, what this means, of course, the question comes up: do these babies are these babies more intelligent because their mothers are more intelligent, because intelligent mothers are more likely to breastfeed, or is it really something about the milk? And this would suggest that it's not the mother's intelligence, it's something about the milk itself. This shows you the adjusted difference, taking into account some other independent factors that we know can influence neurodevelopmental outcome. And even after these adjustments, you still have a 7 to 8 point advantage for the babies who receive, for the babies whose mothers chose to provide their own milk, whether they received it or not. Now this is another study from the NICHD network. You've heard about this one yesterday. And this shows the relationship between the amount of breast milk a baby gets and the advantages in assessment at 18 months. This is the babies who got the least breast milk and the babies who got the most breast milk. And you can see there's quite a difference in the amount. These babies got exclusively mother's milk. And there's an advantage in the Bailey Mental Development Index. There's an advantage in the Bailey Physical Development Index. Then there's an advantage in the Behavior Rating Scale. This is pretty impressive because it shows that for every additional amount of breast milk the baby gets, there's going to be an advantage. So it's in effect a dose response curve. Even at 30 months, we still see the advantage in mental development index and emotional regulation score, but the physical development index is almost significant, but not quite. Probably with more babies it would be. So this is the analysis of these data. For every 10 milliliters per kilogram per day additional breast milk ingested during the NICU stay, the Bailey 2 mental development index was increased by 0.59 points, and the physical development index was increased by 0.56 points, and the total behavior score percentile was increased by 0.99 points. So this is very solid, rigorous, robust data that indicate that every additional amount of breast milk the baby gets, the better advantage he or she will have. This shows these results in the form of a bar graph. MDI on the left half, PDI on the right half, and you can see the difference. I should point out that this scale doesn't go down to 0, so it does accentuate the differences, but you can see them quite nicely here. So what is it about breast milk that improves neurocognitive outcome? I'll tell you right away that we don't know the answer to that. We have some ideas. Is it because the mothers who choose to breastfeed are more intelligent? Not entirely, because the infants of mothers in Luca's study who chose to breastfeed but were unable to had outcomes like the infants whose mothers chose not to breastfeed. This is the best information we have to address this particular aspect. I showed you this already. These are the data from the Lucas study, and the mothers who wanted to breastfeed but were not able, their babies scored just like the ones whose mothers never intended to breastfeed. Is it because breast milk infants have closer contact with their mothers? No, because these babies are fed mostly by tube and are too small and too weak to feed from the breast until they're near discharge. And generally, the mother's not even holding the baby during these tube feedings. So we can't explain it by physical contact between the mother and the baby. Then what could it be? If it's something in the milk, these are possibilities that have been suggested. And I'm going to focus on the first one, which I think is probably an important one. Maybe it's more than one component. Probably it is. But these long-chain omega-3 fatty acids, particularly docosahexaenoic acid, but also icosapentaenoic acid, are very important for brain development, for myelin formation, and also for retinal development. Now we're going to go through not only the long-chain omega-3 fatty acids, but some other specific nutrients that we believe are important for brain development in the preterm infant. These are the ones I'm going to, these are some of the ones I'm going to concentrate on. These were summarized nicely in a paper by Michael Georgiev. And here you see the nutrient, what we know about the brain function and the brain region or process that's affected by a deficiency. And so you can see that iron, zinc, copper, long-chain polyunsaturated fatty acids, and choline all have important effects on brain function. And if we don't have enough of those during this critical period of brain development in the preterm infant, we're going to likely have consequences later on. So let's focus first on iron. The iron needs of the red cells are met first before those of other organs, even the brain. So what this means is you can't assume that the baby's getting adequate iron intake just because he doesn't have anemia. So in iron deficiency, the brain could be at risk even without anemia. Maternal iron deficiency is common in low-resource countries and may cause fetal iron deficiency, which affects the preterm infant's brain development. Neonatal iron status is also affected by conditions that increase iron demand, such as chronic fetal hypoxia, for example, as occurs with intrauterine growth restriction. Iron deficiency can cause immature reflexes and abnormalities of temperament, more crying. These babies are harder to soothe and they're less alert. Iron deficiency can retard development of hand-eye movement, coordination at 10 weeks, and locomotion at 9 months. And neonatal iron deficiency predicts behavioral and developmental problems at 5 years with auditory language comprehension, fine motor skills, and self-regulation. This is a study that looks at the effect of iron deficiency on some of these reflexes that you can assess in preterm infants. And the solid black bars are the babies who have iron deficiency, and the open white bars are those that are normal. And you can see that the babies with iron deficiency have a much higher likelihood of having immature reflexes in each of these 6 reflexes. So it suggests that the brain development is slower, and at the same stage the babies are less mature in terms of their neurologic development. Iron deficiency during the fetal and neonatal periods, as we said, can compromise brain development, but brain development can also be harmed by iron excess. Iron excess occurs in very few disease states in infancy, mainly neonatal hemochromatosis. So in reality, this is not a problem that we should worry about too much. But you can also develop iron excess from overtransfusion. And recent evidence implicates higher transfusion thresholds for preterm infants as a possible factor in neurocognitive deficiencies at school age. And what I'm going to show you about this is some recent data from my institution, where we did a study in the early 1990s where babies were randomized to higher versus lower hematocrit thresholds for transfusion. And we've been able to recall over half of these babies and assess them at school age. And we found some surprising and interesting results. There were 100 babies in the original study. We were able to locate 54 of them and bring them back for testing at a mean age of 12 years. Unfortunately, we weren't able to get very many of the females from the restrictive group. Restrictive means that their hematocrit was, on average, quite a bit lower during the period that they were in the neonatal unit, and the liberally transfused babies had higher hematocrits. Except for gender distribution, the children from the restrictive and liberal groups were similar. Their birth weight, gestational age, and SNAP scores were similar. There were slightly more males in the restrictive group, but it was barely significant. What we found at school age was that children in the liberally transfused group compared to the restrictive group had lower cognitive function scores, global, verbal, and nonverbal. There were possible differences in other aspects of neurological and academic functioning, and there were also lower cerebral white matter volumes in these kids. Here you see assessment of the general intellect and reading, and you can see that the children in the liberal group had lower general ability index. There were trends in the same direction for verbal comprehension, perceptual reasoning, and processing speed, which were not significant, but there was a significantly lower wide range achievement test. The reading subtest in particular was lower. We also assessed verbal memory and motor function, and you can see that there were trends towards disadvantage for the liberal babies in all of these categories. The ones that were statistically significant were the controlled oral word association and the color span visual memory. Here you can see we have only three groups on this curve because there were so few restricted girls, but you can see that the white matter volume is lower in the liberal girls, 2 standard deviations below the mean for the whole group. So before we leave the iron, I just want to say that these results are based on a relatively small number of patients. So I wouldn't say we have the final answer for sure about the impact of transfusion threshold, but it is at least concerning. There are also data in the opposite direction from another study which suggests that the babies with lower transfusion thresholds might be disadvantaged at assessment in infancy. So we need more information about this, and we are planning another study now which will be bigger and hopefully provide better answers, but it's going to be 15 years probably before we know the answer. Next, we're going to turn to long-chain polyunsaturated fatty acids. As I said, these omega-3 long-chain PUFAs, especially docosahexaenoic acid, have important effects on neuronal membrane structure, synaptogenesis, and myelination. In preterm infants, DHA is required for normal brain and eye development. It's delivered to the fetus through the placenta. Human milk has abundant DHA, and formulas for preterm infants in the U.S. now are having some of these fatty acids added. It seems that supplementing the preterm infants with these PUFA, with these omega-3 PUFAs has some advantages that were demonstrated in several studies. I'm going to show you first this one by Henriksen et al. They studied 151 babies less than 1,500 grams who got primarily human milk feedings, and they were randomized to receive a PUFA supplement or a placebo from 1 week of age until discharge home. So even though I told you human milk is pretty good in its level of these fatty acids, we can still see additional advantage by supplementing these babies. The amount that was given was 32 milligrams of docosahexaenoic acid and 31 milligrams of arachidonic acid per 100 milliliters of milk. The PUFA supplemented babies had better recognition memory and higher problem-solving scores at 6 months of age. This is the study of IPOKRaTES et al. Done in Australia that you heard about yesterday. 657 infants less than 33 weeks were randomized to either high DHA or standard DHA diets. They were enrolled within 5 days of starting enteral feedings, and the treatment continued until term or 40 weeks postmenstrual age. In addition, the mothers of breastfed infants were given DHA supplement or placebo, and the formula-fed infants received a high DHA preterm formula or a standard formula. So they had a way of increasing the DHA intake for both the breastfed and the formula-fed babies. They looked at the Bailey-2 MDI and PDI at 18 months corrected age. There was no difference between diet groups in either of these among all subjects. However, if you looked at subgroups, the MDI was higher with the high DHA diet among infants with birth weight less than 1,250 grams, but not among the larger infants. And also the MDI was higher with the high DHA diet in girls, but not among boys, which is interesting. And there was no difference in the physical development index with diet in any of the subgroups. So this would suggest that there's an advantage to DHA supplementation in girls and in babies below 1,250 grams. Efristo. Do we have time for some questions? Okay. Yes.
So finally, what do you think here? When we should start giving the iron and for how long?
When should we start giving the iron? Well, I don't know the answer. Probably the more premature the baby is, the sooner he needs to start it, because the sooner he's going to deplete iron stores based on phlebotomy for laboratory analysis and other things. certainly by, if we talk about the preterm baby, most people start it sometime in the first month of life. At Iowa, we start the iron supplementation as soon as we start the formula. So babies receive only high iron formula. But the amount of iron they get in the beginning is quite low because the amount of formula they get is quite low. So as their feedings increase, the amount of iron that they receive increases also. With the breastfed babies, or the babies who receive human milk by tube feeding, we begin fortification with a commercial fortifier that's made from cow milk that has added iron, and we start that at around 50 ml per kilogram per day, so fairly early in their course. With the full-term baby, we had some discussion about this yesterday, the healthy full-term baby. We start right away, but other people wait up to 4 months. Certainly you don't want to wait any longer than 4 months probably, although some say that you can wait 6 months. So the short answer is we don't know.
For how long when you start?
Until you have appreciable intake of iron from other dietary sources. So if it's an exclusively breastfed baby, you should maintain iron supplementation as long as the baby's taking only breast milk. When the baby starts to eat other things that contain iron, then you can reduce the supplement.
Thank you for your very informative lecture. We have some babies, very small babies, 700-800 grams. We put on breast milk with fortifiers, and we give up to 200 ml per kilogram. And these babies do not gain weight sufficiently. Their brain circumference is not increasing sufficiently. When we substitute breast milk with a formula that contains very high proteins, we see that these babies gain weight much better and their head circumference is increasing better. So what is the best predictive for...
Which is better for the baby?
Yeah, well,
Yeah.
I mean, to give breast milk and to insist on giving breast milk or follow the head circumference by giving a formula that contains very high proteins. I mean, we go up to 4.5 or 5 grams per kilo per day of proteins in these babies.
Yeah, it's a very important question. Thank you for this question. I didn't show you any information on the growth rates of the babies, but in general, babies who are fed only human milk tend to grow slower in weight particular, but in some studies also in length and head circumference. My quick assessment of your situation would be that your fortified human milk doesn't have enough protein. And so you need to find a way to improve the protein level, either by increasing the fortifier, using a different fortifier, or using some additional modular protein. But I would say that the advantages of human milk are so important that I would rather find a way to get more protein with the human milk than to give up and say, let's use formula.
There's only one available here in Greece. There is only one available fortifier that contains 0.5 grams. I mean, we put 1 gram per 100 ml. This is the protein we add to the breast milk.
So you don't have enough still, probably, because the breast milk maybe starts at 2 and you're only getting it up to 3 and not to 4.
This is what is available. There is no other available. So what we do sometimes, instead of putting 1 in 50 ml, we put 1 in 40 ml.
Yep.
Even then, we don't see a good, sufficient growth.
If you send me an email and tell me exactly what you use and how you're mixing it, I'll try to see if I can talk to my nutrition consultants and find a better recipe for you.
Thank you very much.
May I ask you something? Could you think that that would be a different composition of the milk, of the mother milk, if the mother has the baby on her breast versus the mother pumping the milk? Because hormonal influences could be
It's
there?
a good question. I don't know the answer. Joe or Bill or Cami, do you know if there are any studies looking at breast milk composition if the baby's held during feeding versus not held? No. Okay. We know that there are some differences in the composition of of milk from mothers who deliver prematurely in the first week or two. That tends to go away, but early on their milk is higher in protein. We know also that the composition of the milk changes during the feeding, so that at the beginning of the feeding it's higher in protein and lower in fat, and towards the end of the feeding it's higher in fat. So you can manipulate the composition of the milk by selecting which aliquot from the pumping you feed to the baby. But I don't know. It's a very good question, and it's a study that you could do.
But how can you do it? If the baby is taking the breast milk, you cannot, or you have to pump a bit in between.
I think the way to do it would be to take preterm babies that are not strong enough to go directly to the breast and randomize them to tube feeding in the incubator or tube feeding in the mother's arms.
Early growth is good for the brain development, but what about the risk of metabolic syndrome in preterm baby?
Yeah, there are some consequences from growing too fast. That's mainly in the babies that are growth restricted. But I think you have to keep in mind that overfeeding could potentially increase some of those risks in adult life. But I think we all would like to have a bigger brain when we get to be adults and a better brain function, even if it means we're going to have some problems with blood pressure and diabetes. But probably this is not going to be the case in the amounts that we're discussing. Joe?
I think it was about 5 years ago when Alan Lucas and St. Paul came out with a couple of studies that looked at very early growth in the first 2 or so weeks after birth in preterm babies. And this was part of their big cohort, and they looked at these babies when they were between 13 and 16 years of age. And they found a couple of very interesting outcomes. One outcome was that those babies who had the highest growth during those first 2 weeks had the highest 32-33 split proinsulin, suggesting that they would be at higher risk for type 2 diabetes. They also had a difference in flow-mediated vascular dilatation, where they did not dilate their blood vessels normally at 13 to 16 years of age if they had the higher weight gain. But you have to remember, and I think that these studies were badly flawed, you have to remember that the sicker the baby, the very sick babies do not have their normal decline in weight. The sicker babies actually get more edematous. And those are the babies that are most highly stressed. And I think that that's one of the things that they did not look at in this study. And these two studies actually caused a lot of concern amongst neonatologists. And I think that neonatologists actually took that so seriously that they were going to change around some of their therapies, where they were going to go back to not providing the more aggressive nutrition for these babies. So I think we have to be cognizant of the fact that those studies were flawed, and at least in many of our opinions, and that we have to get those babies right back onto their fetal growth curves as soon as possible after birth, and not be worried about metabolic syndrome.
Thanks. Yes.
After this question.
Wait, she's bringing the microphone for you.
How we check the growth? What growth curves we have to use? And please comment the World Health Organization growth curves for babies.
Okay, which growth curves to use? That's a big question. The best is probably Greek growth curves for preterm babies. But short of that, we tend, as long as the baby's preterm, we still judge his growth based on what the fetus would be doing at the equivalent time in gestation. So I think most of us in the U.S. still look at growth relative to the fetus. The growth curve tells you only the percentiles, but without any growth curve, you can still plot the weights in sequence and see if they're increasing at the rate that they should. So I don't know. Joe, do you want to comment on that choice of growth curves, or Cami, or Bill?
I think the point you make about growth curves, sort of specific for a specific region, is very important. So, for example, Colorado might be a little bit different than Iowa in the United States. We were at a conference in India not too long ago where they were talking about getting their babies to full enteral feedings within 1 week if they weighed 1,100 grams, and discharging many of these babies from the neonatal intensive care unit at 1,500 grams. So in India, I think you have a different set of growth curves than you would have in the United States, even though they were using some of the international growth curves in India, but they should actually be using growth curves that are more specific for their population. So I think your point there is a very important one. It's better to have some specific growth curves.
There are some growth curves that are made for postnatal growth of preterm infants, and yeah, I can talk to you later. I'd have to refresh my memory. The names don't come to me immediately, but we could communicate by email. Any more? Okay, thanks.